So welcome everyone to the Modern Ward Rounds Learning Event 5. My name's Vincent Baxter and I'm an Improvement Manager with the Emergency Care Improvement Support Team, and I also have a clinical background as a nurse. We're really excited this afternoon to have Dr Natalie King with us. Natalie is a consultant acute physician at Surrey and Sussex Healthcare NHS Trust, and ward round craft is one of her real passions, and she has led ward round training for the last 8 years, and this was actually featured in the Modern Ward Round Guidance, which was published earlier this year. So Natalie's I've had a bit of a sneak preview of this, so there's not going to be no spoilers, but there's a really exciting presentation that Natalie's going to give. But before that, what we're going to do is, just to get people thinking, is to run a short Mentimeter session. So if you take your smartphones and point them at the QR code that's appeared on the screen now, or if you're having any problems with that, if you just go to the Mentimeter address there at the mentimeter.com and just enter the code below, you should be able to access the questions as well. So hopefully people have been able to do that, and we can bring the first question up. Okay. So we've got a bit of a split at the moment.
Okay, I'll move on to the next one.
Okay, thanks, Crystal. Do you train and learn as part of a multidisciplinary team? And this is just to get people sort of thinking ahead of Natalie's presentation, and hopefully spark a little bit of discussion in the second half of today's session. So, and I think, is this the final question? I think,
yeah.
Crystal, who's in your ward round team?
So you can select as many people as you like for this, as appropriate.
And what we'll do is we will send the results of this Mentimeter session out along with Natalie's slides following the session today, and also the session's being recorded, so you can kind of access that as well.
Great, that's really interesting to see. Okay, I'll come off this now.
Okay, that's great, thanks, Crystal. Okay, so hopefully that's got people thinking ahead of Natalie's presentation, which we're going to hear in a moment. If there are any thoughts that kind of spring into people's minds as you're listening to the presentation, we will have an opportunity for a Q&A at the end of the session, but do feel free as well to put comments in the chat box. So I will now pass over to Natalie. And welcome, Natalie, and thanks for joining us this afternoon.
Thank you, Vince, for having me, inviting me. You mentioned it earlier, this is something that I feel very passionate about and have done for many years now, and I see Pete's on the call, and Pete will remember I spoke at an event for NHSIE, God, many years ago now, about the same thing, so I am still banging the same drum about ward rounds. Crystal very kindly is going to share her screen because my technology is being interfered with Grand Round that keeps popping up on my screen. So what I'm going to talk to you today is really not rocket science. So I know you very kindly said that it was an exciting presentation. It's actually just taking back to basics, and I spend a lot of time talking about basics. So that's me. I am an acute physician. I spend most of my time hanging around the emergency department, and this morning escorting my ECIST visitors around. But I'm also a clinical director, so I look after ED, AMU and cardiology, and I also am the head of school, so I have a lot to do with physician associates in-house and also nationally. Next slide, please. So why did I get the bug about ward rounds? Well, you all met Gordon yesterday, and I'm sure many of you know Gordon Caldwell anyway, and I was his registrar back in the day, 2005, I was working at Worthing. So I was very familiar with his concepts around checklists and the considerative checklist that he helped to develop, that he developed, and was really fascinated by the things we learnt on our ward rounds and the memory hooks particularly that we formed for each patient and how powerful they were in changing the mindset of understanding a patient by their bed number or condition to actually the patient that sat there. And I was really interested to see in the Mentimeter then that the patient seemed so low down on that list of participants within the ward round. And it's probably my greatest take-home message of all of my training, and I'll come to that in a little while. So I got the bug for ward rounds when I was a registrar, and since then I have been interested in them as a concept and how we deliver them, but also around role empowerment and who really should be on that ward round with you. I was amazed that when I did a survey back in 2012 of our medical students, now F1 doctors at the time, so few of them have had any training in actually the fundamentals of performing a ward round, doing it well, looking at safety, looking at patient experience. And yet their portfolio was full of tick boxes and assessments around whether they could cannulate someone, but not whether they could actually interact in a meaningful way with patients, with their team, what that teamwork looked like. And also, as I became a consultant, I was very much aware that so many of the incidents that I looked into on DATEX or complaints really centred back to either things that had or hadn't happened on a ward round. So it really got me thinking and interested in how we could make those better. And at the same time, the medical director at my trust said to me one day, well, here's this checklist, and I really want you to embed it because I want you to train the consultants to do it better. And you can imagine how that went down initially, trying to tell as a new consultant some of our very senior older consultants who were quite reticent about change and actually even being observed to see what was happening on their ward round. So it was much earlier in our days of continuous improvement at my trust where there was a lot of scepticism around it and that of the checklist. But actually we did try and embed the checklist, and it did work for a period of time. And then as with any of these things, it waxes and wanes in how it's adapted. And in the end, what we found is many people were putting a giant tick through all of it with the assumption that it was being done. And so we wanted to do something a bit more than that, to actually embed it as a culture change rather than just another thing that we had to complete as part of a process. Next slide, please. The other thing that we did at the time is that we actually wanted to ask our patients, what they thought of our ward rounds, what were we doing right, what were we doing wrong? And I really wanted to focus on the really basic things. So we did a survey of 100 of our medical inpatients at the time. And although on first glance, some of the data suggested that we were quite good, I kept looking at it in the other way and saying, well, 79% of the lead clinician introduced themselves, but not the team. So that still suggested a fair proportion either didn't introduce themselves, but certainly didn't introduce the entourage of people that may have been with them. And that's how I think you build that relationship with the patient early on in the day, so that when you go back, everything is more fluid and you have that familiarity. And we know this from complaints that a large amount of our patients aren't told anything about their discharge plans. That's all done hush-hush away from the bedside. But how can you start thinking about the discharge process if you're not involving your patient as an active participant? And we also found that although 61% knew what was happening to them in some vague form or another, 39% had no idea what was happening to them. And the thing I say to my students and anybody that's working with me is that time that you spend with the patient for the patient is the most important part of their day, pretty much, in being able to understand what's happening with them and be able to feed into that process. And these are just a couple of the comments that people said, I didn't know who half the people were. And I can imagine from a patient perspective, being faced with a large group of people coming in on some ward rounds, not particularly currently with stretched workforce, But that's very intimidating, and not understanding who those people are. And this for me was key, that they weren't really sure what was happening, but really didn't feel as if they could ask at that point. And then the team go away again. And what was that process to make sure we were answering those questions? Next slide, please. We know that ward rounds, in theory, can be a fantastic educational tool. And there's this huge benefit of the experiential learning that you can have on ward rounds. But how do we know that the person that's leading those ward rounds is an effective teacher, or actually effective at what they're doing? So much that you learn on ward rounds is based on that role modelling, understanding how a clinician makes decisions, and that being explained back to you. But how confident are we when our medical students or our nursing students are going and involving themselves in the ward rounds? How do we know that actually that's a good learning experience for them? How can we assure that it is? And how do we keep the patient right at the centre of that, and that they are the #1 active participant? And you can imagine, as I mentioned to you earlier, the initial resistance that I had was, well, I don't need to be taught. You know, my ward rounds are fine. OK. And that was a really difficult challenge right at the beginning for how we would do that. So I decided to turn it upside down. Rather than training the consultants, I would start to train everyone else and bring them up. And as they came up through the ranks, or they changed what they were doing, that they would then have that culture embedded into them from an early point. Next slide, please. So, I mean, I used to play this clip. It is it's all the Carry On films are not exactly politically correct these days, are they? Quite rightly. But this clip for me, and I remember it from a childhood, of the Sir Lancelot Spratt character coming in and is everything ready, matron, and the way that he interacted with the patient and his team. You know, you hope that these things are a thing of the past, but I know this is back in the BMJ from 2004, but I think most clinicians will still have memories, or even sadly now, have witnessed some periods where ward rounds are really bad and people feel humiliated or they don't feel valued. How can you feel empowered to speak up for the safety of the patient or the experience of the patient if you don't have the confidence to do it, and that you're not invited to be a meaningful participant within the ward round? So I'll just let you read that for a minute, because one hopes that you don't see this anymore. But I'm sure if I canvassed opinion of clinicians or junior doctors, I'm sure that sadly these things are still happening. Next slide, please. So when you have to consider, when you're developing teaching, I was very much not wanting to teach about the actual clinical cases. So in the development of our scenarios, it was thinking about what skills we wanted to test. So for me, my focus was very much on these non-technical skills of how the team work together, who makes up that team, who is your ideal ward round team, how that decision making happens, who influences it, and most importantly, how the patient feeds into that decision making. The communication, clearly really simple things, body language, introductions. And for me, and this was not referenced within this study, but for me it was about empowering those roles, so that if I've got one of the band 6 nurses on the ward round, which is an absolute godsend, them feeling empowered to speak up and challenge where they think things aren't going right, and also being, as I say, active participant and advocating for the patient. And then you can think about putting into the training the more technical elements around accurate diagnosis or prescribing. You can focus on drug chart safety. And that's where it's really come into its own around having our pharmacists involved in ward rounds and in the ward round training. You can focus on things like making the process more lean, the investigations being ordered real time, patient education, and that discharge planning process. But for me, I wanted to keep it as basic as possible to really focus on the key elements of patient safety and experience. What we do know, and this the study that's referenced at the bottom, which is fairly recent, was that when they started to look at F1s performing on ward rounds, that they looked at heart rate monitoring, and the things that clearly stressed the doctors at the time were the multitasking, the managing multiple interruptions, and that fear of performance in front of others, and particularly relatives, that they noticed elevations in the heart rate. So what can we do in a controlled format where you can give meaningful feedback, where you're not having that anxiety-provoking feeling that I'm about to be humiliated on a ward round? How can we make that change? Next slide, please. So the reality of the ward round, this is from a junior doctor's perspective, is that the majority of the tasks that they're doing are indirect care. And the actual specific teaching bit or element of teaching, the time for that is really, really very little. And as I alluded to, there are lots of points within a ward round process that can trigger stress. So again, my training was very much around what can we do to make that feeling of stress go away so that people are feeling calm, they have a process to follow with a structure to the ward round, that they can then feel far more in control of that process and be able to respond accordingly, keeping the patient really at the front of it at all times, thinking about how when they're interrupted, when they have to step off of rounds to complete discharge summaries to enable flow, you know, that has a real impact in terms of the risk for patient safety and experience. Bleep answering. I know Gordon talks a lot about multiple interruptions, and I have to say, before I came online in here, I was in another room where someone was drilling outside, and I immediately knew that that was not going to work very well in delivering a talk. Next slide, please. Oh, Crystal, is it moving on?
Yeah, can you not see that?
No.
Can anyone else?
Is it still on the reality of the ward round? Ah, there we go.
It's moved on.
There we go. So we know that simulation with deliberate practice is a really useful method of training in a safe environment, giving people that space to be able to learn from when things go wrong, but actually in an effective way with good debriefings to really discuss the issues that matter. And as I found when I started to do this, you know, simulation back in 2012 was much more around the mannequin and the high technology responding to changes in event. So for me, it was quite strange. People were saying, you're running simulation, but you're not in the sim lab. And I said, well, we don't need to. Ours is much more low technology. But what it was more immersive so that we could bring a team of people together and just act out a scenario. And we had actors, which was particularly useful, which I'll talk about. There's discussion around whether for simulated ward round training, it's beneficial to do it in groups versus more individual. But actually what it suggests is actually you can scale up ward round training and deliver it in groups. And indeed, you can deliver it in a virtual format without too much loss of educational utility. And actually, it's more cost effective to do so. And there's now, since I wrote a paper for the RCP journal back in 2012, based on our experience back then, there's now cumulative evidence of the role of simulation in ward round training, particularly teaching those non-technical skills from various different specialties, surgery, paediatrics, urology, and I'm sure obviously that's why it featured in the modern ward round guidance. And what some evidence is suggesting is that simulated ward rounds can actually, when it's measured, the error rate can be reduced, which surely has got to be beneficial in terms of translating that into patient safety. Next slide, please. Oh, it's stuck again.
Moved on for me. So
it's moved on to you. Maybe it's coming. There we go. It's just on a delay. So we developed something called the Quality Ward Round Programme, which as Vince said, we've been running since 2012. And we run a number of different iterations of it, but we try and train people together. So we train final year medical students, foundation doctors, our Band 6 nurses on the Band 6 Ready programme, and really importantly for me was using pre-registration pharmacists within the training as well. And then latterly, because I'm the head of school for PAs clearly, we looked at how we could adapt the programme for our physician associate students and qualified PAs. The timing for me is something that's always bothered me, because the feedback unanimously when we deliver it to our final year medical students is, well, why on earth are we not having this in earlier in our undergraduate programme? Because what we found with our PA students delivering it at the beginning of their second year placements is it actually makes their placements more effective in terms of them feeling useful on their placements rather than standing at the back, having an active role in the ward round and actually learning the job and processes in a much more ready fashion because they've had preparation. So we currently run and have run the programme for all final year medical students that we have at our trust. They go through, we run about three programmes of it. We have done, and we've done it at other sites as well, where we've included Band 6 nurses and pre-registration pharmacists. And I think the world's your oyster for ward round training, because you can tailor the scenarios to the level of complexity that you want or different themes that you want to. So actually, for me, my next step's probably going to be thinking about the IMTs that we now have. We've got 11 IMTs and hire trainees and what that looks like, because one minute you're a core medical trainee or an IMT and then you're an SPR, where actually the focus of your ward rounds is very, very different at that point. I dare say, next slide, please. So we've always run our ward round training in groups, and initially we ran them with quite small groups, so we had maybe 6 learners, and then it went to 12, and then when COVID times we've scaled it up quite markedly as we've adapted it to a virtual format. As I said, it's low technology, and you'll see in the top picture there we have an actor, and our actors are very experienced in medical acting, if you like, so they are the same actors that do the OSCEs at our local medical school. And they're fantastic, actually, and we can give them a scenario and all hell can break loose, actually, on the ward round. We don't test that at the level of the F1, and for our nursery, we try and stick it to the basics. But you can see that if you've got the right people within the group, you can do all sorts of things with the ward round training. What I've liked to encourage over the years is having near-peer facilitators, because that's really been shown to be benefit. So the F1s that are trained in August this year will help deliver the programme in August next year. And there's something really valuable in that, and the F1s are always heavily involved in our induction programme anyway. But actually that near-peer delivery really seems to add something, and those take-home messages. And you see how far the F1s have come from when they were training, when they were doing the ward round training, to then when they're actually delivering it. And I have to say, my ward rounds are not perfect, but I learn something every time I run the training. People within the scenarios are allocated specific roles, so you'll have a team lead, you'll have a scribe. You may have someone who's, looking at the drug chart if you haven't got a pharmacist in the scenario, but the pharmacist may not be doing that with our prescribing pharmacist. You may have the pharmacist leading the ward round. You may have someone looking at the OBS chart. And what we try and instill is that someone should be the patient safety and experience advocate. So at the end of the scenario, that question is asked, what was the patient's primary objective and did we meet it? So as I said, the scenarios tend to be themed, but they're not testing people's clinical abilities or clinical skills. The first scenario tends to be without any structure at all, just to introduce people to the idea, if they're not familiar, of the pre-rounding board round standards, what that looks like in understanding who we see first, in what order, and how you can prepare for the ward round before going into it. The second scenario, we tend to introduce some kind of error. It could be something really simple like a drug reaction and the actor's sitting there scratching. Sometimes we've had lipstick on arms to demonstrate a rash, really simple things. But you'd be amazed at some of the responses, and I'll tell you some when you're listening to the language that's used around the actors. And then the third scenario, and it's only 3 scenarios we do in the training session, we introduce some more complex things around maybe decision making, discharge planning, how we deal with difficult patients or indeed difficult colleagues within the team. And over the time, we've built a scenario bank of different cases, different themes, so we can adapt the training to the learner group that we're teaching. Next slide, please. So this is just an example of some of the observations. I scribble notes down while we're observing all of this going on. And the people that are observing within the scenario groups are actually, we get them to scribe, so they're getting their practice scribing skills as well. We get them focused on a specific element. Previously, I've had them doing the checklist to see how actually then we're performing, and then they're delivering that back in the debrief. So this was a patient that had been given pneumonia, had pneumonia and been given antibiotics and had this reaction. And these are just some of the observations that the person leading the ward round, who wasn't particularly nervous, but this automatic language that was coming out of his mouth to the patient. And you think, if I was the patient, and he was horrified when we said this back to him, that, did you know you said this? And he was like, no. And, to say, well, give me a minute, we're only human after all, or someone must have forgotten, we're so busy, these things do happen. And from a patient's perspective, I mean, it's really powerful. So, these are the things then that he will remember and will thinking about how he's interacting with patients going ahead. And this is the beauty in it for me. Like I said, it's not rocket science. Next slide, please. So we do include things. We're very keen supporters of Red to Green and SAFER. We talk about SBAR, and we actually incorporate SBAR into the learning around scribing and also how we formulate the interaction with the patient. But we talk a lot about those interactions, that body language, that etiquette, you know, the registrar bobbing up and down on his knees, delivering bad news to a patient. Really, really simple things that have a big impact on that patient experience. We also focus on devices, so what's in a patient, what needs to come out of a patient, because we know historically when you audit it, we're not checking the cannulas as part of the ward round, we're not looking under the covers to see what's underneath, we're not reviewing those catheters. And the patient experience bit for me is really important around, are we explaining the diagnosis and are we agreeing the plan with the patient? Are we actually involving them in that decision-making process? And then sometimes we do go and explore how we manage difficulty within patients who are not in agreement with plans or with difficult colleagues. We have an interesting filmed scenario of a very rude registrar who's really not engaging and not making decisions in the best interest of the patient. And that's really around role empowerment and how they can stand up and say, I'm sorry, that's not okay. So that's been a really useful development. And just the example on the bottom is we talk a lot about scribing, the documentation in notes, how to structure it, how to make it the right length, to make it useful, and how that can be improved. Next slide, please. So these are historic results, really, because we do continue with our feedback, but over time we have 95 to 98% of our participants saying that rating the training is 5 out of 5 in terms of a Likert scale. We have from time to time reanalyzed it, but we've trained nearly 1,000 people now, so we probably should be collecting it, but to be honest, I don't have enough time in my day. But we have demonstrated statistically significant improvements in the ability to lead the ward rounds and in the documentation and ward rounds at F1 level and medical student level. And what interestingly we found is, even though not all the learners in the live simulations get a chance to lead the ward round, they all show improvements in their confidence. So even if they're just observing and being part of that process, they're still learning and they're still able then to take that on. And for me, as I said 100 times, it's all around role empowerment and that ability to feel it's a safe space to speak out and question and be the champion for the patient. We've adapted the training for our PA students, for our second year PA students. And what we found, as I've said before, is that they overwhelmingly think that it's enhanced their placements, actually. So when they're going on their hospital placements, they're finding themselves to be of more value, more confident, and again, being that patient safety champion. And they've also shown significant improvements in their confidence with documenting as well. Next slide, please. So we find that you very much can adapt it to suit the needs of the learner. So final year students, as I've said, it's part of their preparation to practice, if you like. I think it really should form a really core part of undergraduate training to enable them for their placements, as we do with our PA students. For F1s, it's much more around taking that role of just being a participant on the ward round and how that looks like transitioning into F2 when you'll be leading ward rounds on your own, more managing, more multitasking, thinking about patient safety and experience. For our nurses, it's been a fantastic way of empowering and role understanding. We know our nurses are fantastic patient advocates, but sometimes I've felt that they've not felt empowered to challenge some of the traditional hierarchical structure of medicine, which I'm very into flat hierarchy anyway, but it's around how can we involve our nursing staff more, appreciating that it's not easy to get them onto the ward rounds, but even having them as part of the training really has empowered them to be able to come and appropriately interrupt the rounds to tell us something that's really valuable information, because they do hold the secrets to what goes on the wards when we're not there. And our pharmacists, absolutely, I'm the greatest supporter of having pharmacists within our ward rounds. I cannot tell you day to day the number of errors I find on drug charts, and it's another drum that I bang. And obviously we have medicines reconciliation within acute medicine very, very quickly. But actually, we've had pharmacists within our ED now taking part in the ward rounds in ED, which is hugely powerful for actually providing that level of support as soon as the patient comes into hospital. And it's been for them a very great learning experience. Consultants, I'm not yet there with, I will be honest. I would love to be able to think about what that training might look like for consultants. It's a work in progress, let's say. Next slide, please. In terms of adapting it to the environment, obviously, we used to deliver this face-to-face. there was something really nice about that you actually could be involved in the scenarios, and I get quite excited when I do the teaching anyway. So we had to adapt it really with COVID, and what we decided to do is we used, at the time, our discharge lounge was fairly empty, which is why it looks like a fairly empty ward at the bottom, and we filmed 3 of the scenarios with some of our registrars, some of our PAs. And again, 3 very simple scenarios, keeping it to basics. 1 around structure of ward rounds, 2 around safety focus, and 3 is again around that empowerment to speak up. And we started to run it in a virtual platform. Next slide, please. You can see all the learners there. And we've trialled that for our PA students, and it is quite messy, this slide, I apologise, but the feedback again has been really, really positive around that confidence building, to be able to integrate into the team more, confidence in documentation, confidence in how they're going to adapt within their placements, so that it's actually more meaningful when they're there. And all of them really, really wanted it to be part of their programme long term. What's to be remembered with PA students is you have to adapt the training slightly, because many of them actually, before they go into their YouTube placements, aren't familiar with NHS hospitals. You have to familiarise them. So we do actually a virtual tour of the hospital, so they learn what the place looks like, which could also lend itself well to kind of induction. Next slide, please. I think I'm nearly finished. So we have a rolling programme. We've been training all of our medical students, so it's around 60 a year, all of our F1s, and we trained 3 sets of PA students from 3 of our universities within Kent, Surrey and Sussex. So quite a number of people. I think our next steps are probably going to be a kind of hybrid version. I think there's something really, really valuable in that face-to-face training. And I'd really like to see what that looks like as part of our IMT programme and Band 6 Ready programme, integrating together so that it's much more, again, multi-professional training together. I think there's one last slide, Crystal. This is just some feedback that we've had. So from nursing around understanding the roles that they play, again, role empowerment. The light bulb moment when the CMT realises that having the nurse and the pharmacist on the ward round are really, really valuable. And then the comment at the bottom was feedback from a relative on one of the doctors that had been on the training, which I thought was really, really nice. And I think my final slide is just so this is the e-learning module that we developed. This is fairly old now, to be honest. This is back in 2012, but again, it's the basics, available on the eLearning for Health platform. You'll see the picture in the middle. Some of those people are now, I think the majority of them are all consultants, but they were our registrars or CMTs at the time. And I think the take-home comment for me at the bottom was this, how was this training never not a thing? So if I can encourage anybody who has listened to the talk today to think about really basics, I will share any resources that I have with anybody, because I really feel passionately that I think this should be part of core learning and training for all the professional groups that do ward rounds. Thank you very much.
Thanks very much, Natalie. I think that was absolutely fascinating. Really interesting, that third slide about the patient experience. And also kind of what I found quite interesting was that obviously the level of anxiety and stress that ward rounds provoke in healthcare professionals. And finally, I think it was great to kind of hear how you've sort of adapted that training to suit different learners and the kind of multi-professional nature of the training. So I really enjoyed it. Thank you so much. So I can open things up now. If anyone's got any questions for Natalie, do raise your hand. Pete.
Yeah, thanks, Vince. Hi, Natalie. It's great to see you again. My question is really simple, because I've observed you in action training. Why isn't it the norm across the NHS?
That's the big question. I mean, we've had conversations before with our local medical schools who run various iterations of ward round training, but I don't know, is it time restraint? I think there's something really valuable about doing it in a hospital setting as opposed to doing it in a university setting. I don't know, maybe I'm wrong, because I don't do mine within a ward environment. Usually it's done in the postgraduate centre in a room. I cannot fathom why it's deemed just as important to sign off a cannula than be able to be an active participant in a ward round. It always staggers me that it's not just part of normal practice.
Thanks.
John, I see you've got your hand up.
Yeah, Natalie, firstly, brilliant. Thank you so much for the presentation. Everything we would have wanted, having brought together the teams to the Modern Ward Rounds report, building on Gordon's previous work. Firstly, just a comment that I think through the work that ECIST are doing in this, we're really building a bit of momentum with the partner organisations around focusing on ward rounds, and I think this is an opportunity for professional organisations, the NHS, to get together and drive out exactly what you've been aiming to do, that this is just a core part of what everybody does. So let's use this opportunity. That's my comment. Couple of questions really. Interested that you mentioned the pre-ward round stuff, because I think what we're learning in modern practice, certainly as part of my practice, there's a huge amount of the preparation phase that's done, so that actually you're coming into that interaction with lots of information that you then want to validate and build on. But what about the post-ward round stuff as well? Do you teach that in terms of what needs to happen, how you debrief, how the jobs are followed through? Do you incorporate that in?
We do. We don't focus on it so much because we wanted to focus more on the actual interaction with the patient. Because our ethos was always to keep the patient at the centre of it. But we do talk around allocation of task and that kind of thing, prioritisation of lists. But we're moving towards, I hope, particularly our trust, real-time ordering. So with our computers on wheels, or WOWs, I think they're called now, and moving fully electronic, that's going to enable it. But obviously that's going to also have an effect on the ward round in terms of process. Exactly. And I know when I've been on a ward round with Gordon Campbell, for example, his computer goes with him, but there is time consumed while you're doing that around that process. So it'll be interesting to see how that affects it. So yes, in short answer, we do look at the post ward round bit. We do look at the pre-ward round bit, and interestingly, at the weekends, we do our ward rounds in practice on AMU, for example, quite differently. Because we've got a bed base of 72 on AMU now with one consultant and 3 trainees. You can't possibly round 72 people. It would take you 2 days if you're going to spend the right amount of time. So we actually adopted the cyber principles. So Jason Stein from America, who does the structured integrated bedside rounds, which is very multi-professional. So we get the trainees pre-rounding and I go out and see a cohort of patients, and then we go back into the bay with the bay nurse and we go round them again, giving the juniors the opportunity to actually present management, and actually, rather than just being your scribe as you go along, they really like that. They're able to actually manage the cases, and they all still have a consultant review. It's just a much more lean process. So you can round 72 people in 4 hours, rather than it would take forever. Yeah, so that's been really interesting for us.
One of the previous ones of these webinars was from the cyber team, and struck me that the bit that you and I and many others would really want to do, which is the consultant training, the senior nurse training, because unless we get that right and the team working right, it's going to be less likely that people will be able to use their skills in the rest of the team. But it did strike me that some of the lead roles in the cyber process, and if we were able to link up with that team, that might give us an opportunity to develop something that we can start to test around, leading roles in this as well.
I mean, the ever pushback, and we would love to say that we have our band 6 nurses on our ward rounds. It doesn't happen because we are, as they are, incredibly stretched and doing multiple tasks multiple times. But what we are building into our board and ward round standards is that coming together so that when you do have that interaction, it's meaningful and actually it's handing over the right information so that it's maximising that time with the nurse. And that's really important.
That is the skills lead, isn't it? Because that inviting in, even if they're in the middle of other process, just is there anything you want to tell me, etc. Or those are leadership skills we need to build into the training. But fantastic work. Definitely. Thank you very much for sharing it. Keen to work with you to roll it out more.
Thank you.
So, thanks, John. Lee Dowson has his hand up.
Hi there. So I guess you probably don't want to answer this question from what you've not said so far in your body language, but I'm going to invite you to maybe have a go. So what are the cultural and kind of practical barriers that stop consultants getting involved in improving ward rounds?
I think much of it, dare I say, has been historic. It's a bit like any change improvement, though, isn't it? You've got your early adopters, you've got your people that you go to first because you know that they're the ones that will embrace it. And for our juniors coming through and our younger nurses coming through, is that they're generational differences, and we know that, don't we? That there are these generational differences, that how they accept change. You know, our junior doctors now are different from our junior doctors, say 10 years ago. I'm sure similar to mine, to when I was a junior. So I think things are changing. I'll be honest, I went for what was going to be the easiest route. And actually, I would recognise that my ward rounds were getting better as I started to do the ward round training. They're not perfect, because how can you possibly remember if you wrote down the multiple tasks and complexities of a ward round? How on earth can one person think that they're doing that well without the help of a team or a checklist or something to keep you tracked? You can't possibly, it's impossible. And anyone that thinks they do is wrong.
Yes, brilliant.
Thanks, Lee. So next hand is from Vinod.
Hi, Natalie. Thank you very much for the presentation. I really enjoyed it. I just want to know, in terms of ward rounds, you do the ward rounds in the bedside, don't you?
Yes.
Yeah. I had quite a lot of complaints from the patients while you are talking about my status. And others are hearing. There is a lot of complaints I'm receiving. Has anyone is experiencing the same?
No, so, well, for the training, it's not, the training itself is done in a simulated environment, so it's not done with the patient, so it's not in situ simulation.
Okay.
I think there are two, people are either in two fields, aren't they, over this? Some patients don't mind having their case discussed. So actually, it's valuable time if they can listen in. But for some patients, that's not appropriate and may not be what they want. So I think you've got to find a medium. And I wouldn't say one size fits all. Certainly for the cyber ward rounds, the American system with the accountable care units, all of the interactions and all of the discussion are done with the patient. But then they have everybody in the room, and the patient and their carer or relative are the really active participants. So I think providing people are trained in how to deliver that content in a way that patients understand and don't feel in any way that they're being talked about and go away thinking, I have no idea what they just said about me. I think it's around the language. So I think you could do either or.
Yeah, the main thing is about their information or their condition. We are talking about NHS, and in a bay, we're talking about 10 patients in a bay. And how do we structure? Is there any training, or is there a format you actually look into? This is what we are going to kind of do in the ward rounds, trying to kind of avoid breaching their status or confidentiality.
Yeah, it's very difficult, isn't it? And certainly as the American system is very much based on side rooms, and obviously everyone would love all side rooms in the NHS at the moment, but it's not practical, is it? What I can say from our patient survey that we did back in the day, and we still review from time to time, is that patients don't seem to mind having their condition discussed. And I think there are certain things to a ward round that you would do in your pre-ward round bit, and there are bits as a lead, that part of that preparation phase, isn't it, is understanding who you're going to see, what the current issues are, having that link with the nurse to say, do you know, that might be something we want to have a conversation with after the round and in a more private place. But I agree with you. I think it's a difficult balance. It's so much is that preparation, understanding who you're going to see and what the issues are that will guide that, I think.
Okay, thank you.
Okay, thank you, Vinod. Andrew Rochford, you got your hand up.
Yeah, I've been very good. I've resisted the temptation to sort of repeatedly say me. I desperately wanted to join the conversation. Natalie, thank you. Wonderful presentation, really clear and some great outcomes. And I've been putting some things in the chat as well. I brought it up with Gordon yesterday, and it's an area that I'm really interested in. We talk in sort of management terms about Belbin's roles, which talks about, you know, for those who are not familiar, sort of nine key traits within a team, you don't need 9 team members. You need all those traits covered with however many people you've got in a team. And I think it's a nice analogy for me anyway around ward rounds and multi-professional working. And this concept of competency over professional silos. I just wondered, in the work that you've done and the work that you do with HEE and things, where are we at in terms of competency-based working over and above professional working and silo working within ward rounds?
Interesting question.
I'm not sure particularly, I mean, around ward rounds, obviously there is a drive, isn't there, from HE around multi-professional training. So it would lend itself, because this is a core activity of anybody pretty much that's involved in hospital medicine. What I try and teach on the programme is, as we've alluded to, that those characteristics, you can't have a team of 9 people. In actual fact, many of the roles that we allocate on the ward round, it's actually one person doing it, and sometimes it's just me. And how can you assure yourself that you're going to cover all of those aspects? I don't think you can. The professional, I'm very much into flattening the hierarchy. It's not so much around the training, but we did a piece of work fairly recently with HE around workforce matrix and how you design your rotas based on competency rather than title. So we've been one of the pilot sites for our emergency department, because we've been quite an early adopter for ACPs, PAs. We've got a big team of PAs at the Trust, as you probably know, because I look after them. So I think it's a work in progress, and I hope, because the direction of travel is around multi-professional training, but I'd really want to see it more translated into the workplace. You know, induction is still siloed, isn't it? You go into induction and you're going to a doctor's induction or a nurse's induction. You know, never the two shall meet. Surely there are commonalities, I think, that we can explore there, and what that looks like.
Great, thanks, Andrew. Just picking up at some of the conversation in the chat box.
Sorry, I can't see it.
So saw some comments in there from David Campbell about pharmacists, and I think at the end of that is David mentions a similar sort of training. So I just wondered if David's still on the call, whether he'd like to come in and add any sort of further comments to what he's put in the chat box.
Hiya. I thought the presentation was tremendous, and I think we've got examples of the good practice that you've described. I think the issue is it's replicating it at scale, and I think, well, there's lots of challenges. One I think there's such and I only know my organisation. I've been here for 20 years, so it might just be a Northumbria thing. But there's such variability between individuals within professional groups in terms of capability. And I would like to think that if I was the lead for a ward round, if I put myself in the shoes of a consultant, for example, I would want to have confidence in the people that I was working with, because you want to know that you could rely on them to be good at what they're doing. And actually, I know with the way that modern healthcare is like now, there is variability on a day-to-day basis between the clinical teams that look after individual wards. You know, 30 years ago when I used to go on a ward round, it was the same consultants, same juniors, same nurses, same pharmacists, and it was fantastic because everybody knew everybody really intimately well. You knew what they were good at, you knew what they were not so good at. Now you can be meeting 4 or 5 different new people on almost a daily basis, and that must bring with it some challenges. Otherwise, everything that you've just said, I thought was fantastic, and I would love to have you working in this organisation to be trying to support me getting ward rounds running the way that you're describing.
They're a work in progress, David. They're not. Then it's always continuous improvement. I think, but my only thing I would say is that what we found really useful, and I know Pete will smile at this, is around the standard work. So if you've got the standard work on what your board round standards are, what your ward round standards are, that does reduce some of the variability. But in any trust, you'll have your consultants that are, you know, have higher discharge rates than others. It's how do you find that medium balance? But, you know, and people say, you know, and Gordon used to say, well, how long should a ward round take? Well, it takes as long as it takes, as long as it's right for the patient. Some patients will be quicker, some patients won't be.
I don't want to hog any more time, but I did ask another question in the chat box, which was, do you have pharmacy students, undergraduates involved in the ward rounds training yet?
No, I haven't. And to be honest, during COVID, our ability to actually incorporate other roles into the training, we were very lucky. We carried on with the PA students and the F1s. Medical students we didn't do for a year because of COVID. But I need to get back on it with the nursing and the pharmacy, because obviously for me it's paramount is having that multi-professional element. But it was very difficult, and very difficult with excuse me, nursing staff, you know, challenges are more challenged than the medics at the moment. So it's a difficult one, but I think I'm very lucky that my trust are very supportive in the ward round training.
Well, universities have just been challenged with changing the undergraduate arrangements for pharmacy, and they're looking for placements, and I think a really useful place to exploit would be in training in ward rounds. So it's worthwhile speaking to your chief pharmacist about that.
Oh, I will. Jo will be very pleased. She's very keen supporter of pharmacists on ward rounds.
Fantastic, thank you.
Thanks, David. I've seen the chat box that Lynn Quinney from the Patient Care Network has put that all the stuff that she's hearing around patient participation is music to her ears. And I just thinking back to the kind of the third slide in your presentation, Natalie, I'd just be kind of interested to hear from Lynn what her thoughts are on some of those percentages.
So the percentages on, just remind me, because I'm sorry, I'm a bit snowed down in slides. Which was slide number 3? Was it the percentages of?
It was the 79% of the lead clinician introduced themselves, but not the team, and 58% of patients were not told about discharge plans.
Yeah.
And 61% knew what was happening.
Thanks very much for that, because I did write down, thank you, Crystal, I did write down a comment, which was that those findings very accurately reflected some of the discussion within the Patient Carer Network when John and Nikki Ashby from the RCN came to one of our workshops. Those were just the kinds of things that people were saying. And yeah, I mean, it's, I'm sure that it's the case that when people have been through the training that you've described, which I think is absolutely fantastic. I love the multidisciplinary team nature of it, because one of the things that I often harp on about is I think patients can tell when the clinicians are not working as a team. And I think that has a negative impact. So I think anything that really encourages that multidisciplinary team working is fantastic. And I'm sure that the patient experience improves tremendously once the team have been through the training you've described. If I could just ask you one thing, Natalie, for the slide that you showed earlier to that one, which well, it was the result of the Mentimeter survey, where patients, I think, were 9th on the list of team members. What would you say to encourage the teams out there who are working on the collaborative to actually see patients rather as absolutely critical members of the team? How would you sort of encourage them to do that?
Well, the mantra for the training and the take-home message at at the end of each of the scenarios and the debriefs is I say, what was the patient's priority here? Because quite often it's completely unrelated to what the scenario was about or themed. And so the two questions are, what was the patient's, what did they want from this? What was their key objective? And then did we meet it? And I get them to just repeat that. And so that when they go out onto their ward rounds, hopefully, of anything else I haven't taught them about checking cannulas or catheters, is thinking at the end of it, before I walk away from the bedside, have I answered the patient's priority? And if I haven't, then I've got to go back at some point. Or if my consultant hasn't, and I'm still thinking, what was the patient's objective here and did we meet it? No, they didn't. What can I do as a nurse or as an F1 or a PA student to go back and help with that? And that, I think, for me, is going to be the absolute key. That's why I keep saying it's not rocket science. Actually, if you keep it as simple as possible, those simple messages are the ones I hope that will filter through.
Absolutely. Thank you so much. Really inspiring. Thank you.
Thanks, Lynn. So we're just coming to the end of our hour now, and I've got one of my ECIST colleagues that just wants to kind of mention something briefly about some of the peer support available. But just before we go to Claire on that, I've just got a sort of final question. For my sins, I am a user of Twitter, and recently there was a medical student had tweeted and said that she'd been called by a doctor, and I'm not sure whether this was on a ward round, but it sounded like it. She was called unprofessional and highly inappropriate for using the word fab in front of a patient. It did spark quite a lot of sort of debate on Twitter, as these things do, and I thought it was quite interesting. My little comment on it was that actually that week I'd spent a couple of days up in a hospital up in the northwest, and had actually had the pleasure of accompanying an acute physician on a ward round who was absolutely brilliant. And my comment was, this week I spent some time with an acute physician who actually gave his patients a double thumbs up at the end of every interaction. So I'm kind of just interested from your perspective, Natalie, what's your thoughts on the kind of language that we use in front of patients?
I think again, it's understanding who you're going to see, building that. For me, it's about building that rapport from the outset. When we did our observation studies of ward rounds to see how consultants were doing, and I was observed, apparently I touch people's legs quite a lot, so I'm not sure what that says. That I kind of but I don't know. I'm a geriatrician by training, so I suppose for me it was always about building those memory hooks, understanding a patient. You know, I will see patients. There was a lady who tweeted me last week. I looked after her father 10 years ago, but she still remembered that interaction 10 years ago, and I remembered the fact that her father sailed a boat a year after a stroke. So for me, I don't mind if there's a little bit of familiarity. I think that actually just enables the relationship. There are some circumstances, you know, where it would not be appropriate, clearly. I think it's understanding that preparation, understanding who's in your field, if you like, that you're going to go and see, so that you can play it right. And I think that's an important thing to teach our trainees as well. You know, it's Gordon will say it as well, it's that kind of squatting down at people's levels, fine, but if you then have an F1 fainting because they've blocked off their venous return in their legs, you've got to make sure that it's a comfortable interaction for both parties, haven't you, so that then that confidence comes out.
Great, thanks. And thank you once again for a really fascinating presentation, joining us this afternoon and taking the time to take the questions. So I'm just going to pass over now to one of my ECIST colleagues, Claire Saunders, who's just going to talk very briefly about some of the peer support offer.
Thanks, Vince. Yeah, I just wanted to take a moment to promote the regional peer support group sessions. So as you know, we've split into 3 regional groups and we've allocated a 60-minute monthly session at the moment. So North West and North Eastern Yorkshire session is the 2nd of November. Midlands and East of England session is back by popular demand on Wednesday, the 3rd of November, and London and South East session is this Friday. I just want to say, I think there's 3 reasons you'll really want to attend these sessions. Firstly, it's your opportunity to meet with other participants across your patch. Secondly, it's a way of problem solving and moving your projects on, really driving them through. Thirdly, it's a way of growing your network, which can outlive the collaborative and support you on your continuous improvement journey. So these are your sessions for you to shape, and they aren't recorded. It's just a very supportive environment, and we very much look forward to seeing you at your regional peer support group session. Thanks so much.
Thanks, Claire. So I think we've got a final slide now from Crystal, just regarding sort of the evaluation of today's session. Just to say that we are working very closely with some colleagues from NHS EI to formally evaluate the whole collaborative. But your feedback on the sessions is really important. So I think Crystal's hopefully going to put those details up now. We will be sending the slides out along with the Menti sessions, and this session has been recorded, so people are able to access that. So just while Crystal hopefully sorts that final slide out, I can see her smiling. I'll just pass back over to Andrew Rochford, if Andrew's still on the call, for kind of any sort of final comments from yourself, Andrew.
Oh gosh, Vince, I was busy tapping away in the chat room, so that caught me out. A bit more efficient rather than documenting and putting it in the chat room. I just want to say thank you very much once again to Natalie. Thank you to Vince and Crystal as well for today's session. It's been really inspiring. I hope everyone's enjoyed it as much as I have. And I like to think I'm kind of quite involved in the ward round work, but I've been able to stop and think and reflect, and it's down to the quality of the presentation and the discussion that's followed. So thank you very much. I've got lots of things to go away and think about. Your feedback is really important for everyone on the call, so please do complete Menti and just have a very good afternoon. We're really looking forward to seeing you at our next event. So thank you, everyone. Have a good afternoon, and we'll see you next time.